Continuing on with part 2 of Unit 11, you must memorize the definition of hemolytic disease of the fetus and newborn, and then we're going to talk all about the different types, and again, you need to be able to distinguish between the different types. So let's start with the definition. Hemolytic disease of the fetus and newborn occurs when the red cells of the fetus are coated with IgG alloantibody of maternal origin, and this antibody is directed against an antigen of paternal origin that's present on the fetal cells. Let me just put that into plain English. So the mom has an antibody. It's directed against an antigen on the fetal cells. The reason that antigen is present on the fetal cells is it came from the dad. So this is how it occurs. These IgG-coated cells will undergo accelerated destruction. Remember, that's what our immune system does. We coat things with antibody, so it's recognized by our immune system as foreign, so it will be destroyed. And this occurs both before birth and after birth. The clinical severity of the disease is extremely variable, and it ranges from intrauterine death, which is horribly sad, to a condition that can only be detected by doing a serological test on the blood from this apparently healthy baby. Let's talk about the pathophysiology of HDFN. The shortened red cell survival causes fetal hematopoietic tissues to increase production of the red cells, which then causes an increase in nucleated red cells. And this blood bank and hematology are so intimately entwined. And from hematology, anytime you have a patient with anemia, the response is, oh my gosh, we got to get red cells out of this bone marrow ASAP. And so the body tends to release them prior to them being fully mature. You know, the last part of red cell maturation is when that nucleus is extruded. So again, a sign that we have a severely affected infant is that nucleated red cells will be present in their blood. Organs containing hematopoietic tissue increase in size, particularly the liver and spleen, hepatosplenomegaly. This is because they're trying so hard to keep up with red cell production to maintain a certain oxygen level. If increased hematopoiesis cannot compensate for the immune destruction, then the anemia becomes progressively more severe. A severely affected fetus may develop high-output cardiac failure with generalized edema and a condition called hytrops fetalis, and death may occur in utero. If live-born, the severely affected infant exhibits heart failure and profound anemia. And again, this is one of those situations. We want the baby to live inside, the fetus to live inside the mother as long as possible, because the closer to term that you get that baby, the higher the likelihood the baby will survive. But there comes a time when that condition in utero is toxic. The mom is unfortunately killing her baby, because as these fetal cells escape into her circulation, the titer of the antibody goes up, so the pathogenicity of the antibody increases. So again, in very, very, very severe cases, hydrops develops. Less severely affected infants continue to experience accelerated red cell destruction, which generates large quantities of bilirubin. In utero, the fetal bilirubin is processed by the maternal liver, but we're going to talk about severe cases where, unfortunately, the maternal liver cannot keep up. But in utero, maternal liver will take care of the rising bilirubin levels. After birth, the neonatal immature liver takes over. Unfortunately, the liver is deficient in uridine diphosphoglucuronol transferase, and the bilirubin rises. Bilirubin levels of 20 milligrams per deciliter or greater result in mental retardation or death, and also a condition known as kernicterus. Kernicterus, which is also known as bilirubin encephalopathy, results from high levels of indirect bilirubin greater than 20 milligrams per deciliter in a term infant with hemolytic disease of the fetus and newborn. Kernicterus occurs at lower levels of bilirubin in the presence of acidosis, prematurity, hypoalbuminemia, and certain drugs. So let's talk about kernicterus some more. Bilirubin is yellow, and when bilirubin levels are very high, affected structures have a bright yellow color. If you've ever known anybody who's had hepatitis, the whites of their eyes go yellow, their skin turns yellow, and unfortunately, in the cases of infants, kernicterus could be a real problem because the unbound, unconjugated bilirubin is able to cross the blood-brain barrier. And because it is lipid soluble, it penetrates the neuronal and glial membranes inside the brain. Bilirubin is thought to be toxic to the nerve cells, and the mechanisms of neurotoxicity and the reason for topography of lesions are not known, and it has a real affinity for the basal ganglia of the brain. Patients surviving kernicterus have severe permanent neurological symptoms, which include chorioathetosis, spasticity, muscular rigidity, ataxia, deafness, and mental retardation. Unfortunately, because we're seeing a brain, this patient did not survive. There are 3 classifications of HDFN, which you must memorize for the rest of your life, and these are listed in the order from the least to most severe. They're ABO and other. These are unexpected immune antibodies other than anti-D. And they're KID, CAL, Duffy, all of those blood groups that stimulate immune antibody production. And finally, RH. And this could be immune anti-D alone, or it could be immune anti-D along with other RH antibodies, anti-big C, little c, big E, or little e. In talking about hemolytic disease of the fetus and newborn other than ABO, we're talking about all of those blood group system antigens that have the ability to stimulate immune antibodies. And if this pregnancy is the immunizing event, the first baby is not affected, or it may be mildly affected. Why? Think of your immune response. And this is why the immunology course is so important as a foundation for this course. So there's 2 components to your immune response, correct? Your primary and your secondary. This is the immunizing event. It stimulates the primary immune response. What is the antibody class? IgM. Can those antibodies cross the placenta? Absolutely not. So if this is the immunizing pregnancy, it takes weeks or months for this little machine to get going, producing the right kind of antibodies with the affinity and avidity, and then we get transitioned over to IgG, and we kind of start over, meaning we're building these antibodies, and they have to fine-tune to where they have the affinity and the avidity to stick on and stay stuck on to where this is recognized as foreign and destroyed. So during the pregnancy, IgG may not be produced in sufficient quantity to cause problems. The severity of HDFN in future pregnancies due to other immune antibodies is variable. And so what they do is they look at HDFN for all the different blood group antibodies and what is the clinical progress of the case. So there's certain antibodies that we know that if the mom has an antibody to this antigen, that we're probably looking at an exchange transfusion versus these other ones. The history of these antibodies will then maybe the baby needs to be under the Billy lights or have some other non-invasive interventions done. In hemolytic disease of the fetus and newborn that causes Rh hemolytic disease, the situation is the same as the other antibodies. First pregnancy is either unaffected or mildly affected due to this being a primary immune response. Subsequent D-positive pregnancies will result in severe HDFN and eventually fetal death. And a colleague of mine who practiced prior to Rh immune globulin, she said this woman came in every year wanting to have a baby. And I can't recall if the first baby lived or not. I believe it did. But after that, her antibody, increased in pathogenicity to where every year she came in and she gave birth to a stillborn. And it was really sad. I think she said this woman 10, 12 pregnancies in a row, not giving up her desire to have another child. So again, each subsequent pregnancy, the pathogenicity of the antibody increases, resulting in quick, rapid destruction of D-positive cells. For transfusion, we need to always be aware of the D type because severe HDFN and D negative women who are transfused with D positive red cells, we have to be very careful in transfusing D negative women of childbearing age. A D negative woman who's transfused with D positive cells may develop anti-D, which results in severe HDFN if they become pregnant with a D positive fetus because they've already been through that primary immune response. Here we go on to the secondary immune response, which is much more effective. You must give D negative red cells and platelet products to females of childbearing age. Platelet products, if you ever have an opportunity, if you're in the transfusion service, allow a unit of platelets, let's say it's expired, to settle. You'll see that there are red cells present. Now, they try to keep them to a minimum, but just know that they're there. If D-positive platelets or granulocytes are given, then we must give RH prophylaxis. It's a product called RH immune globulin, and we'll talk about that when we get to RH immune globulin. But in a nutshell, it's anti-D in a bottle. And so what we do is we shoot her up with anti-D, and those D-positive cells that are floating around are coated with this commercial anti-D, and they're destroyed before her body has an opportunity to recognize them as foreign. And the last thing about transfusion, avoid directed donations from husband to wife. Because where are these antibodies coming from? And we had a doctor one time who was going to allow the husband to do a directed donation for his wife. And so let's go ahead and expose this woman to every antigen on her husband's cells that she does not possess so that she can form a plethora of antibodies. So the pathologist was able to intervene and get that order canceled. So again, directed donations from husband to wife should not be done. When a woman becomes pregnant, there is a standard set of prenatal serological tests that are done. And for us, it's the type and screen, the ABO type and the antibody screen. If her antibody screen is positive, you must identify the antibody and determine the clinical significance. Because if it's a Lewis, an I, an M, a P, we're not going to get excited. And if it's a RH or a Kidd-Kell-Duffy, we are going to get excited, and the physician will need to monitor this pregnancy, especially if it's reactive at the Coombs phase. If it's clinically significant, the patient history is very important because maybe she had a previously affected infant. The good news is families tend to stay where they're at during their childbearing ages, so that hopefully you get the mom with the first pregnancy and mom with the second pregnancy and so on. So we have the ability to look up the histories of our patients, and we can see if she had a previously identified antibody, and also as well whether or not she had a previously affected baby. Again, IgM class antibodies are not of concern. One thing is that during a primary immune response, IgM antibodies may demonstrate high thermal amplitude. Again, high thermal amplitude is where these antibodies, they grab onto that antigen and they stick. And after 37, which they're supposed to come off, they didn't read the book and they don't want to. They stay on. And then there's a positive reaction at Coombs, but is it due to this IgM high thermal amplitude antibody, or does the patient both have IgM and IgG that we've transitioned over to the secondary immune response? So this is a case in which you would treat the serum with 2-ME or DTT, which destroys IgM class antibodies, and this allows IgG to be detected if they are present. The antibody may be present, but the fetus may be antigen negative. This antibody could be due to a previous pregnancy or some other transfusion. And with the luck of the draw, this infant or this fetus did not inherit it. If anti-D is present, test the father to determine zygosity of the D antigen. The most common Rh-positive phenotype is R1r, which means the dad's heterozygous for D. So there's a 50-50 chance that the baby will not inherit the D antigen. If it's determined that this immune antibody is causing issues, and one thing they're going to do and follow this mom with is titers. Because if the titers are going up, that indicates that the baby's antigen positive and she's being stimulated. So in order to assess the probable severity of HDFN, amniotic fluid analysis is done. And again, this is based on the history of the antibody. Does this antibody have the ability to cause HDFN and the maternal history with previous pregnancies? She's already had 1 or 2 babies that were affected with HDFN. So again, we're going to monitor the antibody titer to determine if it's rising. And the bile pigments in the fluid are measured at 450 nanometers in a spectrophotometer. You must memorize that number, 450 nanometers. The level of bile pigments correlates directly with the severity of hemolysis of the red cells and how severely this particular fetus is being affected. So the results will determine the action plan. So once again, we've identified the antibody in the mom's serum or plasma, determined that it is immune. After performing antibody titers, determined this fetus does have that antigen because the titers are going up. So we will determine the severity of the disease based on analysis of amniotic fluid at 450 nanometers. And based on that, we'll determine an action plan. Amniotic fluid analysis is indicated in several different types of situations. So let's talk about antibody titers first. Amniocentesis is indicated if the maternal antibody titer is greater than 32 for anti-D, or if it's greater than 8 for anti-Cal, or there's a 4-fold increase in maternal antibody titer from one to the next. Remember what a 4-fold titer increase indicates? That indicates that the immune response is ongoing, and that's a clinically significant rise in titer. Bringing back serology, right? Amniocentesis should be performed at 28 weeks if HDFN was identified in a previous child. At 22 weeks if the previous child was severely affected, and if the maternal antibody increases before the 34th week. So these are all indications that amniocentesis needs to be done. High values of bilirubin in amniotic fluid analyses by the Liley method, or a hemoglobin concentration of cord blood below 10 grams per milliliter, are significant. We'll type the fetus. Recent development in fetal RhD typing involves the isolation of free fetal DNA in the maternal serum. In the United Kingdom, this technique has virtually replaced amniocentesis for fetal RhD determination in the case of a heterozygous paternal phenotype. So like I told you, if you type the father, and this is why you must know Rh phenotyping, the results and interpretations, because if he's an R1r, again, the chances of him having a D-negative child are 50%. So again, utilizing fetal DNA in the maternal circulation has really eliminated a lot of the amniocentesis procedures. But it's not universal yet, so we still need to teach you about this. Maternal plasma exchange may be instituted if the fetus is too young for an intrauterine transfusion. What in the heck does that mean? So what that means is you take the mom and you do a plasmapheresis on her, and then replace the plasma that's removed with donor plasma that has no antibodies. So she's hooked up to a machine, It withdraws a unit of blood, spins it down, takes off the plasma, and returns the red cells to her mixed with donor plasma. So what we're hoping to do is reduce the amount of offending antibody present in her plasma. Unfortunately, this can have a rebound effect, meaning when you reduce the antibody level, the body's like, oh my gosh, how did we get this so wrong? And they'll just double down on producing more. So determining, based on the fetal age, will determine how often this procedure needs to be done. So let's bring back your body fluids course. So amniocentesis, as you recall, they use an ultrasound to direct the needle so they don't stick the baby. Back in the old days, it was a hit or miss, whether or not you'd hit the baby or not. So this way they don't hit the baby, they withdraw the fluid, and on the right hand side you see the amniotic fluid. It looks kind of like serum because there's a lot going on. The products of metabolism are excreted into the amniotic fluid. So again, it looks very serum-y looking. So this graph illustrates the analysis. If you look at the left-hand side, there's the OD at 450 nanometers analyzing this fluid. On the bottom are the weeks of gestation. And based on the reading, we'll determine perhaps intrauterine death is at a risk down to the bottom where the fetus is unaffected. Most of us growing up in the transfusion service, we use the Liley amniotic fluid zones, and I want you to memorize the different zones. Zone 1 is unaffected or mildly affected, no interventions. Zone 2, deliver at 36 to 38 weeks based on fetal lung maturity. And then Zone 3 is seriously affected, either intrauterine transfusions, if they're not born yet, or preterm delivery if it's indicated. And if you look at this chart on the right, so again, here's the weeks of gestation, here's the OD reading at 450 nanometers. So we have intrauterine transfusion, we have immediate delivery, and then there's that gray zone. What do we do? And that's going to be based on other additional tests that are done to determine whether or not the baby can be safe, not safely, but is ready as possible to be delivered. So in analyzing the amniotic fluid, this allows the physician to determine and weigh the risk in a severely affected pregnancy. Respiratory distress syndrome is a real concern in preterm infants, and this is due to the inadequate surfactant and lecithin levels. Remember, those are what, when we breathe in and then we breathe out, our lungs kind of go together, and without sufficient surfactant and lecithin, they stay stuck. So they have to weigh those risks. And they determine in the past fetal lung maturity by lecithin-sphingomyelin ratio and the amount of phosphatidylglycerol in the amniotic fluid. And so these tests, again, will help assist the physician in choosing the best path for this particular situation. If the lungs are not mature, then an intrauterine transfusion will be performed. Unfortunately, even with best efforts, you got to remember this little person inside, the little fetus, if you've ever been pregnant, they are bouncing around and jumping around. So unfortunately, sometimes the amniocentesis, you might nick the baby, causing a little bit of bleed, which can cause what's called a fetal maternal hemorrhage. Fetal blood enters the maternal circulation. If amniocentesis is done for other reasons, and the woman is unsensitized D-neg, we're going to give her Rh immune globulin. So I want to say that one more time. Let's say I don't know all reasons that they do this procedure, but if it's done on a woman who is D negative and she does not have anti-D, then we will give her that Rh immune globulin. And just for grins, I'm going to tell you, it will cover a 30 ml whole blood bleed, meaning it's enough antibody in their anti-D to coat 30 mLs of D positive cells so that they'll be recognized by foreign and removed. If the D type of the fetus is unknown, it's also given to prevent immunization. Cordocentesis, you draw blood from the umbilical cord for laboratory analysis. And to the extent possible, when trying to determine the viability of the fetus, using non-invasive procedures when possible is always the best route. Intrauterine transfusions are our last gasp effort to save this fetus. It's performed after careful evaluation due to the high risk to the fetus. It's given to prevent hydrops fetalis and fetal death. It's rarely feasible before the 20th week of gestation due to the size of the developing fetus. Everything's too small. And once it's started, it needs to be administered every 2 weeks. So the mother needs to be fully informed of what the procedure is all about, and that this will have to continue every 2 weeks until delivery. Memorize the criteria for intrauterine transfusions. Blood must be less than 5 days old, low risk of CMV, either CMV neg or CMV safe, which is your leukoreduced products. It must have a hematocrit 80% or higher, and we will actually adjust the hematocrit to what the physician wants. The blood is O negative and compatible with mom. Because what if mom, in addition to anti-D, has anti-big E, anti-Kel, or maybe you missed something? So ultimately, the blood that is selected for transfusion has to be cross-meshed with the mother. It has to lack antigens to which antibodies are directed. It must be irradiated, and we're going to do about 75 to 175 mLs, and that's determined by the fetal size and age. This is a doctor determination. I've prepared many units for intrauterine transfusions, and again, it's all on the doctor as to, they will tell you what the hematocrit will be. They will tell you what the volume will be. What's very, very interesting is that after multiple intrauterine transfusions, the red cell testing on the fetus will not be accurate. They will type as O negative, as 90% of circulating red cells will be donor cells. The only reason we're doing this is because of the massive destruction of their red cells by the maternal antibody. So what our goal is to replace that blood with blood that will have a normal survival time in the fetus. The direct antiglobulin test will be negative. But if you look at it microscopic, in my experience, it is positive. The indirect antiglobulin test will be positive because maternal antibody will continue to flow into the fetus. But the good news is, because these donor cells lack those antigens, they will live a normal, happy life. The cord bilirubin is not an accurate indicator of the rate of hemolysis or of the likelihood of need for exchange transfusion after birth. So what we're talking about here is a situation that is within the baby. And so, again, you cannot trust the testing after delivery. Knowing the history will be crucial in this type of situation. And we hope that this mother will deliver at our hospital so that we can continue following and taking care of the baby once it's born. So intrauterine transfusions are done in the hospital. And so the physician will do an ultrasound to determine the position of the fetus and the placenta. And they'll use a local anesthetic to numb the site. And they may give the mother medication to slow the fetal movement down, because we don't want the baby jumping around when the ultrasound will be used to cannulate the umbilical cord vein. So, because we need that needle to be set in there for the entire procedure. Sometimes, back in the old days, I don't know that they ever do this anymore, but back when I first entered the field, they used the peritoneal cavity versus the cord vein, but we didn't have ultrasound. What they found was if they inject blood into the peritoneal cavity, it will be absorbed into the circulatory system. Unfortunately, that has a high level of risk because what if you hit the liver or the spleen or some internal organ. So right now, to my knowledge, the cord vein is used. So here's a picture, and we had a lady that she had anti-D, and she was pregnant, and she wanted, of course, this baby to be saved. And so because this was the second, the baby was severely affected. And so she needed to have intrauterine transfusions for her fetus. So I got permission. I was able to watch the procedure, and it was so anticlimactic. The mom's there chit-chatting with the doctors, and they went ahead, and she'd already had several of these before. Remember, once these are started, they have to be done every 2 weeks. And so what they do is they have a little stopcock device where you can see the physician on the left-hand side. They're pushing the blood. And then they wait, and then they flip a stopcock and they withdraw a certain amount. It's very slow because we don't want to just give, and the baby now has hypervolemia, but we don't want to withdraw the 10 or 15 mLs and then fill them back up, because unfortunately that would cause cardiac arrest in the baby. So it's a very slow, deliberate process. I think it took maybe an hour. And after the procedure was done, I asked the doctor for a sample of the blood that they'd taken. And so I went to back to the lab and I tested it. Sure enough, because the baby had received several intrauterine transfusions, they typed as O negative. And because I'm just, I'm the scientist. I need to do it myself. And it was just so cool. So that's how an intrauterine transfusion is performed. Of course, intrauterine transfusion is not without risk. And the one that is most concerning, of course, is fetal loss. And a study from August 2017 found complications and loss statistics have decreased dramatically over the years. Procedural-related perinatal loss rates declined from 4.7% to 1.8% per fetus, or from 1.6 to 0.6% per procedure. Procedural-related complications occur more often before 20 weeks. Bradycardia is common but usually transient. Bleeding, usually transient and mild. And preterm labor is a risk which does not occur very often. This is the end of Unit 11, Part 2.